Your doctor isn't the problem, the system is blind. That's the problem. Right now, the average patient gets seen and then disappears. No data, no signal, no clue what happens next. And the gap? It's where people spiral. It's where diagnoses get delayed for years. It's where $280 billion quietly burns every year. But now imagine this, an AI calls you not to replace your doctor, but to notice you. It hears your voice, it sees your face, it tracks tiny changes over time. Not what you say, but how you say it. The breakthrough isn't diagnosis, it's continuous context. A founder could build this into anything: medication adherence, employee burnout, customer health, because behavior is the ultimate data set. This isn't theory, it's already happening. Systems are learning from millions of conversations, refining models, reducing admin times by up to 88%, and turning check-ins into predictive intelligence. So if your product could actually understand how your user feels, how would it change everything you've built? Welcome to AI for Founders, I'm Ryan Estes. In this episode with Larson, CEO of Videra Health, you'll learn how AI is decoding human behavior, why most founders are missing the biggest data layer, and how this tech is reshaping healthcare, SaaS, and anything driven by human decision-making. This is for builders who want an unfair advantage in understanding people. If you want that edge, go to aiforfounders.co. We study what's working before it's obvious. We give you the playbooks before they're called best practices. If this made you think differently, please leave a review like you're grading a startup pitch. Brutally honest and wildly helpful. And if you want to get booked on podcasts that actually move markets, go to kitcaster.com. They don't just get you interviews, they position you as the authority in your category. Top founders trust Kitcaster to turn conversations into customers. That's Kitcaster by Moburst. Oren, welcome to the show.
Thanks, Ryan. I'm excited to chat today.
Yeah, I'm looking forward to it. So a big theme of this podcast is health tech, med tech, pharma tech, everything tech, but particularly in the healthcare industry, I think there's some really amazing opportunities that we're just coming into now. So I'm really excited to learn a little bit more about your company, Videra Health. So give us an introduction to your company.
Yeah, so maybe I'll start with the company I was at before called HireVue, where we did video-based job interviewing, and a company could interview 100,000 people in a week. You could take an interview where you might be rejected based on your resume, but you'd have a chance to sort of tell your story and be heard, whereas you'd never have a chance otherwise. And it was a really amazing company to build. At some point, we added AI to that. This is like 2012, 2013, that would listen to the interview and help surface who the best candidates were and say, look, you had 1,000 people interview this week. Here are the top 50 that you need to meet, or the top 10 you need to meet for the company, and let people who might be biased against or discriminated against get sort of seen for what their actual abilities are versus what hiring managers or recruiters might think about them. And then that really led us into sort of saying, could we apply this into healthcare? Could we start to use this ability to see and hear a person and understand who they are in healthcare? And I think there were sort of two ways we thought about that. The first one was, when you leave a doctor, you're on your own. Like, you go, you're seen, you get probably pretty good care, and then when you leave, no one thinks about you again. And we wanted to use AI to sort of say, can we just check in on people all the time with AI and ask them how they're doing, and then use algorithms to measure how they're doing, and then surface people who are in crisis or need care back to their providers who don't have time to check in on everybody, but they need to know about the 5 people today who really need help. And then the second use case was kind of around, could we diagnose diseases and see them earlier? Because you'll hear about people like, oh, it took me 7 years to get diagnosed with that. Like, maybe that's a solvable problem. So that's where we started with Videra. Obviously, there's a lot beyond that, but that's kind of what we started out to build in 2019 and have been building ever since.
Incredible. So with your first company, the automation for video interviewing, did Videra come out of that, or what was the outcome for that company?
We sold that company in 2019. It's still around. They just did an acquisition today that they announced. So that's continued to grow. They've interviewed 100 million people for jobs since then. And there's no relation between the companies other than we had sort of learned a lot about how to understand someone from a video. And, we took that learning and expertise and took it into healthcare.
Great. So is Videra Health, is it a video platform?
Yeah, fundamentally, we want to see people. You'll often hear doctors say, like, if I could just see my patient for like 15 seconds, I'd know how they're doing. And so we really believe in the power of video. Now, not everyone wants to engage in video, so people can just talk, they can text in a lot of cases. But yeah, the idea is ask people questions, see them, hear them, quantify their responses, and then get them the care that they need.
Cool. Okay. So the customers then are actually the clinicians themselves?
Yeah, I mean, we're usually selling to bigger health systems in the behavioral health space. People treating people for substance use, eating disorders, mental health, those kinds of things.
Great. Okay. So you sell into the big hospitals. They provide this as an opportunity to their physicians. How does it kind of integrate into kind of the hospital's tech stack that they have already?
Yeah, I mean, one of the really interesting things about healthcare is how, which I haven't seen in other areas, is the reluctance of the system of record to let anybody else integrate. So there's a lot of challenges to integration and plugging into those workflows. So that our perfect world is the clinician doesn't have to think about this, right? Like if a clinician has to make a decision and think, oh, maybe I should put this person in a follow-up program to see how they're doing, chances are they're busy, they're going to forget how to do it. There's some friction there. So ideally, we're looking at the record and saying, okay, this person missed an appointment. Let's do a check-in. They got this diagnosis, they got this prescription. Let's follow up and see how they're doing a week later, 2 weeks later, 3 weeks later. This person just got discharged. Let's do a reach out and follow up and see how they're doing. So hopefully the trigger is automatic. Then we manage the connection with the patient, collect all of their data, and then push that back into the health record so that hopefully and trigger an alert so that if there's something that needs attention, it will be seen by the right people. But hopefully you just get notified of things you would have wanted to know but didn't think about wanting to know or figure out how to get it, or you just see better patients. In other words, a lot of times our healthcare system sees people who are good at making appointments, not the people who actually need to be seen. But with this, you can kind of reach out, engage people who might not proactively reach out, and then go, hey, you know what? We're going to have someone call you, make an appointment, and get you back in. And so providers should have the experience of just going, man, I'm just seeing a lot of people who really, really needed me today, versus people who are just, yeah, I have a little bit of anxiety, which is perfectly valid. But there's people who are sitting on waiting lists and sitting at home suffering who aren't getting in.
That's great. Doctors are really good about learning about people who are good at making appointments. It's that's the realest thing I've heard all day. It's so true.
Yeah. Yeah.
That's why the moms make all the doctor's appointments for the family, because if it was up to dads, it wouldn't get done.
No one would go.
Fascinating. Okay. So let's say that I'm the patient. Now it seems like there's certain kind of like diagnosis or conditions that this makes a lot of sense, especially video, right? So like mental health, like literally at a glance, you can see how somebody's doing, right? Are there use cases that are maybe more beneficial than others?
That's a great question. I think, we focused on behavioral health up front. We started on something called tardive dyskinesia, which is a movement disorder. And it looks like someone kind of has involuntary movement, usually around their lips or their mouth. And you might see, so once you've seen it, you kind of start to see it in public. There was never a good way to diagnose it. Only 15 to 20% of the people, even today, have been diagnosed. And so we started with that because it was inherently visual. And we've started working on other movement disorders like Parkinson's disease, et cetera. So things that are like the clinician has to see you to diagnose is really important. We do a lot of depression, anxiety, PTSD, which you can measure from voice or language if you have enough sort of turns of the conversation with people. But we've really focused on mental health and behavioral health for now. But we're building things in Alzheimer's and Parkinson's as well.
And define behavioral health. I'm not sure if I know that exactly what that term means.
Yeah, I mean, it's used in a lot of different ways, honestly. It's anything that is related to your behavior, where we can't say, oh, you have a virus. It's about your behavior, how you're acting. So, I mean, there is an underlying cause to that, but it's usually not well understood. So anxiety, depression, PTSD, schizophrenia, bipolar disorder, And then you start to see things like maybe ADHD gets bucketed into that or other categories. So those are the types of things.
Okay. Well, like addiction and things like that.
Substance use falls into that bucket as well. Yeah.
Yeah. Okay. Okay. Totally get it. Um, Amazing. So then, as far as the AI integration, exactly, what tasks is AI performing in the app?
Yeah. So, what we've talked about so far is kind of, how do we assess a person with AI, which needs to be a conversation, right? So if I reach out, if you get a text from your doctor, Ryan, and they say, "Hey, Ryan, how are you doing?" You click a link, it opens on your phone, and the AI says, "Hey, how are you doing?" You go, "I'm good." Like it has to read from that you might be good, but you might not be good. We've got to ask something else to understand that. And so it has to have a conversation where it's not just hearing what you're saying, but how you're saying it, and then making the next word, just like a human would, if who was well trained and understood people and was fully paying attention, had the time, um, and then sort of quantify that. So AI is doing essentially an interview to check in with you. That's highly calibrated, responsive to who you are, what's happening with you in the moment. And then one of the other fascinating things that has kind of happened in our platform is this. A lot of people, when we started selling this, would be like, "Oh, this is amazing technology. Like everyone should be doing this." And we'd say, "That's great. Well, when would you like to, sign a contract?" They're like, "Oh, we wouldn't do it. I mean, we can't afford it, but everybody else should do it. It's great. It's really cool." And so I think that was one of the big learnings for me was there's a lot of things that people think are cool or think are even really valuable. Would be do a lot of good in the world, but if they can't directly find a way to pay for it, it probably isn't going to get paid for and deployed and used. So we've had to add a lot of other solutions that have a little bit more obvious ROI because providers don't really get paid more for following up and checking in with patients. They get paid for seeing them in a visit.
You bet. Okay, I'd love to get onto some of those other applications, but I'm really getting the picture now. So I get a text as a patient from a doctor's agent that it wants to do like a video call with me. So am I going to see kind of like a human avatar as I'm doing an interview, or is it audio?
It's audio, and we've done 100 million-ish interactions like this, and I still believe that the avatars are not the right way to go yet. Someday they will
Yeah.
be. I still just don't think they're good enough to create a authentic experience with people. It's my personal opinion. What I think is interesting is that the research is that when you're interacting with an AI versus a person, you actually will say more
Yeah.
uh, because there's nobody judging you on the other side. AI is not judging you; it's just asking you questions. It's appearing empathetic, but it's not really thinking like, "Oh man, that guy's a jerk. Oh, what a loser." Like it's not thinking that. At least we don't think it is. Um,
Yeah.
and so people will say more, but we've done a bit of research on the video avatars, which is a bit of a rabbit hole, but yeah, it's really audio and you see the question, you respond, you're on video, we're able to see you. And I think in the very near future, we'll have the video avatars, but right now we haven't done it.
Yeah, no, it's a big step, you know. I mean, they say that audio is a warm medium because you're using your kind of creative intuition to give it a face, whereas video is a cool medium because you're just basically being entertained. So I'd love to hear a little bit how you settled on a particular voice that would be the agent. Yeah, are you using like an English accent or like a Mississippi accent, a Jamaican accent?
It's really that's been a big debate of what to do, and I think we're still fine tuning the voices. Honestly, I think they keep getting better and more emotive, and so they're changing quite often. One of the goals that we've always had, even back at HireVue when I was there, was to really let a person kind of choose their own adventure. Like who would you like to be talking to? What voice would you like to talk to? What's the persona of the person? I want them to be like me. And so I think we're trying to make it kind of something that people can pick without creating more friction in the process. Because I think some people love to hear the guy with the English accent or the girl with the Australian accent, and I don't know the science yet of whether you'll say more authentically to one or the other. Um, but yeah, the voice selection's very tricky.
Yeah, so you allow them to demo and choose the one they like. What's the winner? Is there an overwhelming winner? The
It's
one that's on the top?
No, and I'm saying we're just adding that ability to let people select
Oh,
that.
sure.
But what I found fascinating is like I'll think a voice is great, and then we'll go like, oh, let's show that to this new customer that wants to buy the product, and they'll be like, oh, I hate that voice. The voice is terrible. And I'm like, I thought it was fantastic. So there's a lot of personal preference here that I think we're still trying to figure out.
Yeah. I mean, me personally, if it has an English accent, I'll never answer the phone. I'd be like, I don't want to talk to some Englishman. Like, what am I doing here? I want a nice Southern, maybe Texas, like a lady, that's nice. Then I'd be like, okay, yeah, I'll have a conversation with you.
Yeah.
What's really interesting about this kind of like generative AI and prescriptive AI and communication AI is we're trying to replace, or not replace, but we're trying to duplicate what the best of the best do. And a lot of that comes from talent that it's hard to replace, like communication and being able to kind of speak in like a non-judging way with good journalistic questions to get the most out of the person they're talking to comes from a lot of experience. But also there's a lot of kind of intangibles that you can't quantify, whether it's body language or, a little twinkle in the eye, a little wink here and there, or how attractive the person is. So that's got to be like a big leap too when you go into video, is like you can't have some super hot nurse that you're talking to. People are going to fall in love with the bot,
Yep.
which we
They're
know
going to
won't
want to say things
happen.
to impress them that aren't necessarily true.
Right, exactly. Then you're getting into the situation which I've found myself in sometimes, which is like you have to lie to the AI. Now, and I'd love to get your take on this because a lot of people find themselves in a position where they can't be totally honest with their physicians. I think probably behavioral health could be a huge one, especially if we're talking about addictions, especially if we're talking around people that have issues with pills, where they're going into doctor relationships with a very specific prescriptive need. So, which is to say that some people go in and lie about their condition. Could you imagine that to get drugs?
Yeah.
So
It's a
some
problem.
what's that?
No, it's a huge problem. I mean, I think people
Yeah.
obviously go in with a desire to get an outcome, not and that outcome is not necessarily to get better; it's to get a prescription, right?
Yeah. Or the other side is like you're going to mask some of your behavioral issues because you don't want to get dropped from your life insurance policy. Or there's so many like banana peels in healthcare and like health coverage and all of these things that people aren't necessarily incentivized, to be honest.
Yeah, it's a huge challenge, and I don't know that we can solve that yet. I think one of the questions is like, how can you tell if they're lying? And all the research I've seen on lying is pretty disappointing. Um, it's very hard to detect lying. Even if, I mean, the research is a few years old, but even if you had someone in fMRI, like it's only like 80% accurate at detecting lying. Even sort of police and people are like, oh, I can spot a liar. Turns out when they're tested, they actually can't. They're barely better than average. Some are actually worse than because they're overconfident in their assessments. So lying is a hard one. I think what we try to do is create space where people don't feel like they're being judged. And what I've been very fascinated by, even back to when we had job interviews where it's a high stakes situation in a job interview, like, I want to get this job. And people would say things that are not actually in their best interest. You kind of create a sequence of questions where they begin to get momentum and they just start to talk. And they say things you're like, I probably wouldn't have said that in that situation, but they do reveal it. Um, and we're trying to not replace human judgment here. We still aren't. I mean, Utah just passed a law that you can refill prescriptions with an AI that you call. I think that I don't know. That might not be the best idea. That's all I'm saying. Um, maybe at some point, but I think we still want to provide a bunch of data, hopefully collected in a way that someone's going to share as much as possible, and then get all of that to the clinician so they're really well informed, and we can look for inconsistencies, right? Like, well, they answered this question this way, they answered it that way. The answer this week was different than last week. We can surface those kinds of things, but ultimately, I think we're still in the age of clinicians should make those kinds of decisions.
Yeah, totally. It's so there's like, there's good faith that goes into this, of course. There's always going to be bad actors, but those will be on the fringe. I would predict that most people would want to use it because they're trying to kind of fine tune their dosage on whatever particular medication so that they feel the best, and, the dosage across medications are kind of notorious that like you have a, you take a pill for something and like you have a peak experience and then it kind of decays until you take the medication again. So I could see a use case for something like this. If it's like 3 days since your last dosage, they can check in on you and be like, hey, how do you feel? Be like, actually, I feel great now. And they can start to kind of calculate, what amount of the medicine is in your body at that time and maybe kind of like change some of the prescription and the dosage to affect each individual case. Would that be fair to assume?
Yeah, I think that's a great use case. And I think that's where we want to get here, where medicine is very personalized. We keep track of what every single person's response is over long periods of time, see when it stops working. Medication will work for 6 months, then it stops working. And now you need a change in dosage, you need a change in med. A lot of the medications that get prescribed in mental health clinics don't work the next day or 5 days later. They take a few weeks to start to have effect.
Sure.
But that might not line up with when you have an appointment. So we can go in and check in and say, hey, is it working? Are you having side effects? Are you still taking it? Oh, no, I stopped taking it because of the nausea. Okay, well, that'd be good to know instead of waiting for 3 more weeks for your next visit, right? And really collect detailed information about each person and then be adjusting based on good data, which today it's mostly reliant on how smart your doctor is.
Yeah, and ultimately it's anecdotal. It is like, how are you feeling today? A good buddy of mine has an app that basically traps or tracks GLP-1 treatments. Because GLP-1s, you take an injection once a week, and the dosage is like hyper personalized. But really, the recommended dose is like, hey, start with 8, go to 16, go to 32. Hey, how you feeling? Okay, change it. And they're doing 100% dosage jumps a lot of times. So really what his app does is tracks anecdotally like how somebody's feeling on the 5th day. And like if that's the day, then maybe that's the dose you start with. And then you can kind of subsequently learn more and more and more. So application like this, it seems like it makes a lot of sense because, the other thing is if I'm journaling, how do I feel today? Fine, get out of here. But if someone's talking to me, it's like, no, how's your energy? How is, your nausea? How is whatever the side effect may be? You can start to see and track over time conversationally where it's at. And, particularly, what I'm also interested in is as we kind of move into like this more predictive or prescriptive function with AI is really as it learns more and more individually about people, how you can detect other things. So I'd be curious to say, like you said, for example, with audio, you can detect some behavioral health issues. And I spoken to another company, Canary Health, that does exactly that, where they can actually listen and hear and diagnose, mental health disorders based on your voice. So are there any particular kind of indicators through video that AI is getting better at picking up?
I mean, like movement disorders, like we talked about, even just flat affect is a sign of Parkinson's disease. And the challenge is trying to boil it down to one feature it's rarely like one feature. It's a combination of 5, 6, 7 different things. Which is why it's hard for a human to necessarily explain why that person sounds depressed, or is that different than sounding what somebody with a movement disorder would sound like. And so, I think we're doing some very similar things to what Canary is doing in terms of recognizing mental health conditions. We're looking at movement, but also the voice and the words. And so it's all of those modalities combined, which I think is really important. But our vision is that you should be able to take one test. Your doctor checks in with you every month or two. You talk to the AI for a few minutes, and we're telling you if you have Parkinson's, if you have early onset dementia, if you have, a movement disorder that's beginning. There should be 30 or 40 different observational biomarkers being detected, and check, how those have changed over time. Has something been creeping up, but it wasn't critical, and now it's crossed a threshold? Has, if you jumped off your baseline by 2 standard deviations, okay, then we should probably act on that and alert a clinician rather than wait till your annual physical.
Yeah. It's just going to be so fascinating as the capabilities get more and more refined. And, now if you can pick up Parkinson's, which has probably a pretty dramatic like visual cues, but, more and more where Videra gives me a call and I'm like, hey, it's like, how you doing? I'm like, I'm doing terrible. Oh, I feel horrible. I'm bad. And it's like, oh, Ryan, I can tell you're a little dehydrated and tired. Maybe take a nap. You'll feel much better. You're like, oh, yeah, you're right. Actually, that was what it was.
Yeah, yeah. I mean, it is funny how often something basic like that. I mean, we did a study on substance use with one of our customers on what's the biggest predictor of someone completing treatment and being sober 12 months later. Turns out, do they sleep at night?
Yeah.
Everyone gets super, worked up on all these other things, and it's like, well, if they're not sleeping, they're not going to get better. Like it's just what the data is saying, and we sometimes forget those basic things that an AI could just be like, hey, is the patient sleeping? Oh, help them, give them some stuff to help them sleep, and their chances of getting better is doubles.
Yeah. It's like that old commercial from the 80s and 90s. This is your brain on drugs. It's two fried eggs getting fried up in a skillet. It could be really like this is your brain without sleep. And the problem is drugs are keeping you awake. And now you're getting this kind of, lack of sleep induced psychosis. And of course, I am not a physician, but like, it's interesting. Some of the studies around that as people start to sober up, their brain clears out largely because they're resting.
Yeah. It's a big part of health, the sleep for sure.
Then the AI is going to be nagging me. I'd be like, oh, I'm terrible. It'd be like, Ryan, you need to work on that sleep. Be like, I know. I've been trying. I got sleep apnea. What do you want me to do? I can't sleep on my side all night. I want to sleep on my back.
Then it'll tell you what to do.
Arguments with AI. How many people? Cool. Tell me a little bit more what went into kind of the personality and affectation. How did you approach that? And how do you approach kind of the questions to ask and the questions not to ask?
Really good question. We studied the questions pretty thoroughly, and it makes a big difference. I mean, we like to work in an environment where we're structuring the questions versus listening to a conversation passively that doesn't have anything to, if you ask somebody if their favorite, somebody who's depressed, you ask them how they're doing the night after their favorite team won the championship, they're going to sound great. They're going to sound different, and you're going to lose some of that. So we like to have a structured conversation. We're really asking about their feelings and how they're doing. That elicit the right things. We've published a paper on kind of studying tons of different sort of seed starter questions of where the conversation needs to start to have the best reading of the person. And then I think when you're sort of picking features of what matters, I think it's important to go in with as few assumptions as possible, right? We don't want to go like, oh, we think that you can read that by the way that they squint their eyes. I'm just making that up. That could be completely wrong. And so, we're for these algorithms that are predicting observational biomarkers. Yeah. So, when we're training a model on predicting something, these observational biomarkers, we're going to have somebody answer a set of questions, take a standard screener for depression, anxiety, trauma, and then figure out which of those features help predict that the best. We don't necessarily know what that is. I mean, we could guess at it and be wrong. And there's really no need to do that. Just train on as many features as we can get, as much data as we can get, and then figure out, is the model a good model? And then you want to look and see, does it pass the sniff test? Does it make sense that these things are predictive? And are they introducing bias? You always want to be making sure that you're not really good at predicting depression in white people, but not black people, right?
Yeah. Yeah. How's the memory? Is it able to learn from multiple use cases and get better and personalize maybe to each particular patient?
I think that's one of the things that we're just adding now. It hadn't been a big part of our focus, but you really wanted to get to know you, and every conversation should have some memory. You also don't want it to make assumptions like, oh, well, Ryan's depressed, I'm going to talk to him like that. You might not be depressed today when we called. You might be feeling completely different. We don't want to almost lead you back there because we think a certain thing. But we do want to remember things. If you're like, yeah, remember I lost my job. Like, it should know that somebody lost their job and not be like, oh, well, what is it that's bothering you? Remember I lost my job. Like, how many times do I have to tell you? Like, nobody wants to have that kind of a conversation. So it's trying to figure out what are the things that sort of bring forward that are helpful and useful rather than just generalizing and treating somebody like a stereotype.
Yeah. Well, that's a good point. Like, is there a risk here of re-traumatizing people?
Yeah, I mean, I think that's one of the things that we struggle with, right? Is if somebody's doing great, you don't want to sort of ask a set of questions that make them depressed again, right?
Like,
Or
don't you
feel
remember your wife died? Be like, oh yeah, I guess I forgot.
totally forgotten, and now I was feeling great, and now thanks. Yeah. So I think that is a concern is we don't want to have the measurement elicit or create a feeling that we don't want. We want to measure what's there as much as possible. You can't completely separate the two, but we try to be really mindful about that. It's a really great question.
Yeah, I mean, the edges of the mean always show up in conversations like this, and it's a little bit frustrating because, there will be people, I suppose, that will be re-traumatized, but there's also people that eat couch cushions. There's people that eat balloons. So like, should we not have balloons because some people will eat them? It's hard to say. So there's like a compassionate delta there of like, okay, most people are going to get a lot out of this. Some people, it could be horrible for them, and then that's not for them, and that's okay. There's big conversations around people falling in love with their chatbots, or they're having, chat GPT induced psychosis. It's like, yeah, man, but like, people are out of their mind. So like, what are we looking at the edge for when like the mass majority of us can really benefit from tools like this? And I think what's interesting too is like, it's almost the earlier you start to use something like this, the more data it gets on you or gets and learns about you. And so the better the model, the higher the fidelity, the more it's going to be able to be in a position to really customize to your needs. And speaking of models, like what models do you use? Kind of what's in the tech stack behind the AI?
I mean, it's a variety. It's a variety of things. I think we're using for the predictive models, and we've traditionally used transformer models. We're moving beyond those now for all of our predictive algorithms. Obviously, a lot there, but and then we're using LLMs. We're fine tuning LLMs. We've collected a lot of data now from patients, how they interact. We have a clinical documentation tool now, so we're listening to conversations between providers and patients, which is also sort of seeing both sides of the conversation is very informative about how better to interact. And so we're fine tuning, large language models with those data sets as well, to be better at having conversations that are the way real conversations happen in behavioral health, not how we think they happen or how ChatGPT might think they happen based on very, very generic data sets.
Yeah. Cool. Hey, I want to go back to the bias question too, because that one, it seems like the LLMs largely have figured this out a little bit. It was kind of like or a couple of years ago when Gemini, they're like, make a picture of the founding fathers, and it was a bunch of black guys. So how do you train for cultural, racial, sexual orientation, these kind of biases that oftentimes the LLMs have a hard time picking up on?
Yeah, or they pick up on them so subtly that we don't realize they're picking up on it, and it sort of shows up in weird ways. Yeah, I mean, the only way that I really know to solve for that, after having done this for a long time, is make sure that you have data sets that are not obviously wrong, right? Like there's the famous case of from the hiring world of where Amazon was predicting a certain type of candidate. It's like, well, it was only trained on high performing men. Of course, it's going to pick up signal there that predicts men are going to be better than women. But that may not be, you actually might want the opposite, which is like, let's get more diversity in the organization because women can be good too. We just didn't train it that way. So there's that. And then I think and that all would have been avoided had they tested it, right? If you sort of test and say, do we score women higher on depression than men? I mean, obviously there's a lot of nuance to that, but you have to test it. And so whenever we build a model, we build model cards that sort of show what's the the false positive, false negative rate on each demographic group and intersectional groups, because you might be good with black men, but not black women, right? And so you've got to look at all the intersections between that and continue to monitor that. I think those are really the three things: good data sets, testing, and then monitoring, because these things can drift over time and start to take on weird behaviors. Is like there's subtle changes in the population of who's there, of who's being seen by the system. So I just think it's really important to be looking at that all the time. In hiring, it's actually funny because it's regulated, right? If you discriminate against a group, you're legally liable. Like that's illegal. In healthcare, it's like, Wow. I mean, what are we going to do? It's hard. And so I think we have the opportunity to actually start to treat people, I don't want to say equally, but I want to say precisely, right?
Yeah.
Because men and women definitely need different things at different times in their healthcare journey. They don't need the same things, but they need the right things for them. And what happens often is, one group will just get a prescription, another group will get something else. And that's very imprecise. That's
Yeah.
just based on bias.
Yeah. Well, and the fidelity of this will get greater and greater the more we adapt these tools in different capacities, and the more that like kind of the hive mind learns about each person, because especially behavioral health, mental health issues, it's very nuanced. Of course, there's going to be cultural kind of standards and norms. Like I'm talking into cameras all day long. So if I was to approach a tool like this, it'd be like, I'm pretty comfortable doing that. But like some people, it's a new concept. Maybe they're like, I don't like FaceTime or whatever. Like, so there's all of this cultural difference that I think really comes down to as soon as you are, which is so cool because it's only going to get just more and more developed as it knows you. Because for example, I spend a lot of time with the Lakotas, and Lakota women are largely pretty demure, and they don't really make a lot of eye contact, and they don't shake your hand firmly, but that's just how they do it, and so like if you're interviewing somebody like that, Lakota women, you're not going to have any of that kind of understanding. So you'd be judging them against some other group that's like very outgoing and, gregarious.
Yeah. Yeah. I mean,
And
these cultural nuances are really, really important. And, that doesn't mean that person's whatever, depressed because they did that. It just means that's what they've always done. That's what their culture does. But somebody else from a different population would do that, and that would mean something. Yeah.
yeah,
Yeah.
yeah, it's fascinating. Okay. What are some of the other features that you're working on within Videra?
Yeah, I think one of the things that we realized, and I alluded to this earlier, was like this is really cool technology, but it doesn't necessarily make us more money. It's just cost. And so we really tackled things like clinical documentation. We tackled things like intake. So if you go to a CCBHC, which is a certified community behavioral health center for Medicaid, you have 2.5 to 3 hours as a patient of intake that you have to do before you can be scheduled to see a therapist, which is often means get put on a wait list. Like that's a terrible experience when you came in and said like, hey, I'm really struggling. I need some help. They're like, not a problem. We'll get right on that right after 3 hours of asking you a bunch of questions that feel like they have nothing to do with what you came here for. Like that's a terrible experience. And a lot of people don't show up. And the no-show rate at the next appointment is surprisingly pretty poor. And so if you could have AI do that interview, because the issue is the system also doesn't have the people to do that well, right? Like you alluded to earlier, there's a big difference between sort of the peak performer. Like if you get someone who just is amazing at that and can ask you the right questions and understand what's going on with you, fantastic. But most people aren't that. Most people are new on the job. They haven't done it for very long. They're busy. They're overworked. They're stressed. They got stuff going on at home. Like they're not giving you their best every day. But if AI could bring a consistent experience to you, it can do it in less time and free up people to go actually help people get better, not just collect data for forms that go in a system of records. So we focused a lot on that intake process of how do you get someone to care, and then how do you document that care and really capture what happened, which again is offloading administrative work, but also allows the provider to actually fully pay attention to the patient in front of them, which
Yeah.
I think is a really important change. Because I think we've all had that experience of going to a doctor and have them be typing in the system or thinking about, okay, I got to write that down. I got to remember that. They're not fully present with us and actually helping us get better and listen to us.
Well, and they're usually going through a series of questions in a form anyway. They got a laptop open, the worst part about a doctor is just getting to the dang doctor. It's like you got to get through the admin in the beginning, and there's an iPad there that you got to sign or something, and then there's somebody with some sassy language, and you're like, all right, man, and then you're waiting, and then they take you back to a room, and you're waiting, and like the whole experience is always you got to check a box, fill out a form, here's a clipboard, all of that stuff. I think like really encourages people to not see their doctor as much as they can because it's just massively inconvenient at best, you know.
Painful at worst, and then you don't really go until it's almost too late, right? Like you're
Yeah.
much worse off than you would have been if you just gone in early. And so, yeah, I think we just need to streamline all of those experiences for patients so they get to care, and then just have the people we can afford to have in the system doing work that's directly related to making people get better,
Yeah.
and do a little less paperwork. So we've built a solution that does all those things. One other cool thing that I really like, it's called our Elevate product. It's supposed to elevate the quality of the team, which gives the provider feedback. So it actually listens to the conversation and says, "Hey Ryan, like when you were talking in that conversation, like when he said his dog died, you laughed. Like that wasn't very empathetic. Like here's what you could have done instead, right?" And so being able to give direct feedback to a provider to say, "Hey, here's how you could be better with the patients," I think is really important as we're trying to sort of say, there's this debate of whether AI can be more empathetic than people, right? But I really firmly believe that, yeah, that's probably true for a lot of people. But we could all get better. And I think we really want our people in the system helping people get better, but we want them to continue to get better and not be replaced by AI. Because we
Yeah.
need human experiences.
This episode is brought to you by a dangerous idea. It's called reading, specifically the AI for Founders newsletter. 47,000 founders strong now, and it's the good stuff. No top 10 AI tools that will change your life written by someone who doesn't ship product. It's just real breakdowns of what's actually working in AI. Who's raised, who failed, who pivoted, and which founders quietly built $1 million in ARR while everyone else was arguing on X. It's written for people building with AI. Every week you get tactical frameworks, unfair advantages, breakdowns of real companies, and the occasional existential question about whether your startup is intelligent or just well-branded. It's free, it's sharp, it might mildly offend your current workflow. Go to aiforfounders.co and subscribe before your competitor does. Because the only thing worse than being replaced by AI is being replaced by a founder who reads. That's the newsletter at aiforfounders.co. Now back to the show. 100%. Yeah, I think it can be more empathetic, or at least it can like notice things. I've worked on a couple of prototypes from just conversations because I'll go back and listen to my interviews and I'll be like, dang it, he said that and I totally missed it because I was thinking about asking the next question. Whereas AI can be like pick up on some cues. It's like, oh, wait, let's back up. But what did you say right there? Repeat that. Like there's a lot of time. There's absolute gold in human conversation. It's just a matter of you got to pick in a shovel to get at that gold,
Yeah.
So I could see it definitely helping there. Nice. And the administrative too. I mean, I hate to beat up on healthcare, but the whole industry is just like being able to like share data and do anything is like pulling teeth for the patients ultimately, which, leads to kind of a worsened experience.
Yeah. So hopefully we'll have magical healthcare experiences that are precise to each individual here in the next few years. That's what I hope for. So
yeah, it's coming. How did you finance the project?
Say that again.
How'd you finance the company?
Oh, great question. Well, we've self-funded it for a while, out of pocket, and that got hard. So we've raised two seed rounds of funding to date, and we're raising a Series A right now.
Amazing. What are you looking to close?
We're raising $12 million. Yeah.
Nice.
So
for go-to-market, how'd you find your first customers?
Well, I have a co-founder who's a clinical psychologist, and that is part of why we ended up going down the behavioral health path of all the different places we could go. And really became people in our personal network, people who we would show it to and they'd be like, oh, that's amazing. I want to use it in my clinic. And then we also sell to pharmaceutical companies in a sort of an interesting way. And we sort of started thinking about like who would benefit the most from patients who are being not diagnosed, who could be, right? If somebody can diagnose and there's actually a treatment available, but you can't get the treatment unless you've been diagnosed, who would benefit from that? And so we ended up knocking on doors of pharmaceutical companies who we thought would benefit from more people being screened. And so it was a lot of talking to one person, do you know so-and-so over here? And just a lot of, years of, and it was a long process, a very long process. Nothing in healthcare is fast. I thought when we went into it, my joke was like, oh, this is gonna be like 3 times worse than selling to HR technology. Not that that was bad, but it wasn't like HR technology was like the fastest buyer because they don't have the biggest budgets, et cetera. And it's like 3 times worse than I thought it would be. It just takes a long time. It's hard. For a lot of probably good, in some ways good reasons. People are careful. And it's just funny how we spend so much on healthcare and nobody's in the business seems to have any money to spend on technology.
Yeah. Well, and there's a lot of hoops you got to jump through before you can even start selling the product. So, I mean, I see on your website you're HIPAA compliant. There's a lot of compliance that goes into it. How was it kind of getting stuff pushed through all the compliance?
I think it was challenging, but we had done this sort of before. We're coming from a regulated industry in HR. We had a lot of regulatory burden. We were in 180 countries, so we'd done a lot of, we'd done GDPR, which is, U.S. sort of got privacy legislation later, so we'd already been through that. We had done FedRAMP certification in our previous company, so we were really familiar with sort of government regulations and security. And so one of the things that I've really appreciated about technology in the last 5 years is it's made it so much easier to get compliant. Yeah. You have continuous audits of your systems, which took teams of humans before, and now it's just sort of automatic, and you get alerts that something needs to be adjusted or a test failed, and you go fix it. So that part I think has gotten a lot easier, actually.
Nice. How big's the team?
We're 25 people right now.
Nice. How does it break down as far as like production, sales?
We're still pretty tech heavy, so we're about 14 people in machine learning, engineering, product design, and then we have 2 people in sales, 2 people in marketing, 3 people in customer success, kind of thing. So still, that's kind of Series A. Like, we've proven this works. We've proven deployments. We've proven people like this. We've proven a market. Now we're scaling.
Yeah, Series A, sales and marketing. Yeah. Cool, awesome, man. When are you looking to close the round?
As soon as possible. So yeah, I mean, we've got commitments, but we don't have a lead, and so that's where we're at. Yeah. We need to get a lead for the round, and then we'll be good.
Cool. And if you want to pass on information about the raise, there's a lot of people that read the newsletter that are venture capitalists or in looking for deals. The VC is so frothy right now. There's a lot of people with money to deploy. So happy to share, spread the word. Lauren, you mentioned that NAMI is an important nonprofit that you support. Now I really kind of get why, obviously. Yeah. But you want to give us a little kind of breakdown of what the work that NAMI does?
Yeah, I mean, NAMI, I'm not an expert on everything that they do. They do a ton of things in the community, raising awareness of mental illness, supporting patients and their caretakers. I think we often forget that when somebody has a mental illness, it affects not just the individual, but whole systems of people who are affected and who try to take care of them. NAMI does a lot of good in the world, and if you're looking for a nonprofit to support, I'd look them up.
Incredible. Lauren, this has been such a fun conversation. Congrats on your amazing company. Where's a good place for people to connect with you personally online?
You can go to laurenlarson.com, LORENLARSCN.com. That's my personal website, or viderahealth.com.
And Videra Health is VIDERA health.com. And I spell it for the LLMs because it's juice right now as far as like AEO.
Yes. Thank you for the spelling.
100%. Lauren, thank you so much for joining me. I really appreciate it.
Yeah, really fun.
You are about to spend anywhere from $100,000 to $300,000 on your kid's college education. And that's not a small bet. And right now, there's a very real chance that they graduate and can't find a job, not because they weren't smart enough, not because they didn't work hard enough, but because the job market changed and nobody told them. Employers are hiring AI native candidates, people who don't just know their field, but know how to work with AI at a professional level. And most colleges are not teaching this, not even close. AINativeStudent.com is the program that fills that gap. It takes high school and college students and teaches them how to actually think and work with AI the way top companies expect on day one, so your investment in their degree actually pays off. You're already paying for tuition, housing, textbooks. This is the one thing that actually makes it all worth it. Go to AInativestudent.com because a diploma is a starting point. Being AI native is what gets them hired. That's AInativestudent.com.